Good Coast and good afternoon on the East Coast, and welcome to the Davies Use Case webinar being presented by Stanford Children's Health on Preventing Acute Kidney Injury, the NINJA report. This is a Davies Award-winning use case for the value of health IT. Arnold Simmons, the man of quality and patient safety, and it's my pleasure to moderate this presentation. HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and enable patient safety tools for all healthcare organizations, patients, and community members as vehicles for improving patient outcomes. The HIMSS Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who utilize health information technology to improve patient outcomes and value. The Davies Award's winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health IT-enabled care delivery. It's a pleasure to welcome two speakers for today's webinar, Dr. Scott Sutherland and Dr. Jonathan Pelmer from Stanford Children's Health Services. I'll turn the presentation over to you all.
Pediatric nephrologist at Stanford University.
Jonathan Palma, a neonatologist and medical director of clinical informatics at Stanford Children's Health.
And the title of our use case is Preventing Acute Kidney Injury, the NINJA report, where NINJA stands for nephrotoxic injury negated by just-in-time action. The low problem we wanted to address is best characterized by the concept of nephrotoxic acute kidney injury. What we'll do today is define the concept, highlight its impact with an actual clinical case, and discuss the background information that we used to design our IT-based solution. Over the decade...
Okay, I got it off for pause.
So over the past decade, hospitalized children have become more complex and more ill, with far more multi-system disease, and these children require far more therapies, including multiple medications. Medications are considered nephrotoxins. These medicines are injurious specific to the kidney, and this is associated with AKI, or acute kidney injury. It's a well-established event which is associated with death, longer length of stay, and the subsequent development of chronic kidney disease. To illustrate this concept, we wanted to present a case which occurred recently. And this 12-year-old boy with cystic fibrosis who was admitted with a CF exacerbation. Upon admission, he was started on vancomycin and zosyn, two medications which are known to be nephrotoxic. After several days, his lung function continued to deteriorate, and tobramycin, another nephrotoxin, was added. Shortly thereafter, his creatinine began to rise, and he was diagnosed with AKI. His creatinine increased over 5x, and while he didn't need dialysis, his course was severely complicated. And these are types of cases that we're really looking to prevent. This is our preventative strategy on a quality improvement initiative which was developed at Cincinnati Children's. Their nephrotoxin awareness program, NINJA, and now Stanford Children's, is one of 9 additional trial centers. The concept of NINJA is to identify patients who are exposed to a large nephrotoxin burden and then to screen these patients for AKI. The project is designed to increase awareness of nephrotoxins and to fit a conversation about alternative agents or discontinuing unnecessary agents if possible. The collaboration gave us a list of nephrotoxins and definitions. They gave us a mission, which was to eliminate all preventable cases of nephrotoxic medication-associated AKI in hospitalized children. And there's a vision, which was that children should only get the nephrotoxic medications they need for the duration that they need them. And then it was up to us to use IT resources available to implement our own solution. And with that, I'll turn it over to John to talk about some of the technical aspects.
Yeah, I'm happy to be able to share some of the design and implementation of both our workflow and subsequently how IT was incorporated into that workflow. And there are several details on these upcoming slides that I will not necessarily read all of, but they will be there for your reference because we do want this process to be replicable at other sites. So the project team came together a couple of years ago when the clinical stakeholders, Scott from nephrology, Tiffany from pharmacy, became aware of the NINJA Collaborative and the opportunity to prevent any injury locally at Stanford Children's Health. So Scott approached me in clinical informatics, and I pulled in one of our IS analytics programmer analysts named Emily Tan, and we got together and started having regular meetings every couple of weeks or so to figure out the workflow we're trying to address and what IT solutions we that may be able to use. So this is just a sort of depiction of some of the process of going through developing the workflow that I don't necessarily need to read everything on the slide, but it was quite important for us to, on the clinical informatics side, to really understand the details of the NINJA Collaborative. So on the flip side, we could help explain to our clinical stakeholders the different IT tools we could potentially deploy to meet the needs of the NINJA Collaborative. So ultimately, we proposed that we would use an electronic report. But it is just an electronic tool. Really, at first, we need a workflow to be supported by the tool. And so much of that was going to fall to our pharmacy team. So a pharmacist that rounds with each of the acute care clinical teams would really be the person who could help put this tool into action. And hopefully we could support their workflow using IT. Certainly we went back and forth, and I'll share some of this later about which IT approach we used. And it was important for us to become more embedded on the clinical teams and have them really understand a little bit about the NINJA Collaborative too, in terms of concerns about nephrotoxicity and the promise of preventing AKI using an approach like this. It's important to highlight that oftentimes when we're doing IT implementations, it's easy to kind of forget the last step or a potentially important last step, which is clearly defining an outcome and tracking that outcome. I think a lot of IT projects are put in and used, and you're not really sure what the outcome was. So this was a nice example where, because we were already working with a quality collaborative, the outcomes had already been defined. And so whether those outcomes are defined because you're part of a larger quality collaborative or because you're working with your local quality improvement department, I think there's a really important aspect of quality improvement that relates to these projects beyond just the work you develop and the tools you develop, so you can follow outcomes and see the impact of your work. So we aligned the NINJA Collaborative, and we monitor the rate of nephrotoxic medication exposure per 1,000 non-ICU patient days, and then the rate of acute kidney injury in these patients as defined by a creatinine level 1.5 times a patient's baseline creatinine level. Transitioning into how health IT was utilized, we'll first share the overall clinical workflow and then how IT was incorporated and some of the details of our solution. The clinical workflow that was developed by our project team, again, had the clinical pharmacist at the center of this workflow. And really important that that person identified the patients who were exposed to nephrotoxic medications. And I'll talk about the criteria for that in just a moment. After identifying those patients who were exposed to nephrotoxins, it would be the pharmacist who would communicate directly to the care team about a patient who has been exposed. And this takes place while the team is rounding on patients and while they're rounding on that specific patient who's been exposed. really the only intervention was a recommendation that screening labs be checked in the form of daily creatinine levels. It's really up to the team to decide what they wanted to do. And interestingly, you'll hear that this prompted a lot of conversations and various approaches to addressing nephrotoxic medication exposure. But a couple of their decision points included, did they want to do laboratory screening of either kidney function or nephrotoxic medication levels? And what did they want to think about in terms of changing medications, whether it's adjusting dosage, the duration of medications, or potentially choosing different meds. So to drill down a little bit on the precise criteria for the NINJA Collaborative, this is actually slightly old data now because it has been updated with additional nephrotoxic medications. But on the left, you can see the list of nephrotoxic medications that count as exposures. There is a little footnote because another example of why it's important to have an IT process for this, why it would be sort of onerous to do manually, is that some medications are considered exposures for 7 days following their administration, while the rest of the medications are considered exposures for only 48 hours after they're discontinued. So you can imagine that an electronic tool would help you keep track of which things continue to be exposures and not. So an exposure is defined by either being on an aminoglycoside for greater than or equal to 3 days, or greater than or being on greater than or equal to 3 of the nephrotoxins listed on left at one time, taking into account that temporal aspect that I mentioned already. On the last slide, I already suggested what the recommendations would be, and strictly based on the NINJA Collaborative, it really was just to consider screening for AKI daily using serum creatinine and checking drug levels of nephrotoxic medications. Not surprisingly, the opportunity for IT to facilitate this process was at the beginning, at the identification of patients with nephrotoxic medication exposure. So we developed a NINJA report that automated the process of the criteria I showed on the last slide to help identify those patients who were exposed. And downstream from that point, the process was the same. It was still up to the clinical pharmacist to communicate with the care team, and the care team to decide what they wanted to do. There have been multiple iterations of the NINJA report, and I will share the latest with you. So because of being on an electronic health record, things like provider orders, med administration data, and laboratory data were all available electronically to be pulled into a report that help us better identify these patients. So this is an example of the report. On the left side, we're taking advantage of some of that patient information, including medical record numbers, name, and location of the patient, so the pharmacists know who they need to communicate to the team about. In the middle section, there are details about the nephrotoxic medications that are ordered, including some more detailed data, like when they began, ended, or when the most recent dose was administered. Because lab data is also available, patients who did have serum creatinine levels performed have those levels listed on the report as well. And so that helps us in establishing what we believe to be the patient's baseline serum creatinine and monitoring for development of acute kidney injury. The report also incorporates the logic that is defined by the NINJA Collaborative. So this slide shows how the report looks when you meet one of the criteria for a nephrotoxic medication exposure. So at the top in red, this is a patient who is on over 3 nephrotoxins, so that shows up in red. There are 2 patients here on the bottom who you see are only on 2 medications, but they are both on aminoglycosides, which have been administered for greater than 3 days. So they also are flagged as patients being exposed to nephrotoxic medications. So I mentioned that the report has evolved over time. One of the work has evolved is in terms of the content and the criteria included in the report. And this really is parallel to the NINJA Collaborative. So the list of nephrotoxins nephrotoxic medications has been expanded from 45 to 61 items, so we now have a greater sensitivity to exposure to nephrotoxins. And we also added the stem cell transplant and hematology oncology patient population to those being monitored. And this is really a high-risk patient population that is often exposed to a lot of nephrotoxic medications. So really the report evolved in a couple ways that would identify a lot more patients exposed to nephrotoxins. And then in terms of the technical implementation of the report, we started with a business objects report from our reporting data warehouse, which is about 24 hours behind what actually was happening clinically in the hospital. And relatively quickly, that did give us a chance to kind of iron out the logic of the report and the way it worked, but relatively quickly we realized that that was limiting in terms of the impact we were able to make on patients and preventing AKI by being delayed in acknowledgement of exposure to nephrotoxic medications. So transitioned that report to the actual transactional area in Epic, so now real time. So now we're using a reporting workbench report in our electronic medical record. So in real time, we know what is going on in terms of nephrotoxic medication exposure. So Scott will revisit the clinical case and walk you through some of our outcomes.
So the goal here is to come back to our case and see how Ninja has the capacity to modify behavior and outcomes. So in this case, Ninja would be triggered right here at the point when the third nephrotoxin is ordered. And once triggered, a discussion would ensue on rounds about the medications and the risk for AI. One possible outcome is that the medical team would decide that they no longer needed vancomycin, perhaps on culture results, and that medication would be discontinued. Once discontinued, the patient's nephrotoxic burden is reduced substantially and the exposure goes away. Ideally, without additional nephrotoxic injury, the patient never goes on to develop AKI. So that's a way in which Ninja can prevent both exposures and AKI events. So now we want to talk a little bit about the value which we and the patients have derived from our invention, the value from preventing cases like the one we just described. So this is our local data since starting the project, and what the right shows is the rate of nephrotoxin exposure. You can see that our baseline rate was right around 9 exposures per 1,000 patient days. In early 2016, as John said, we spread Ninja from our 3 existing care teams to both the HEMONC and the stem cell wards. And we knew this would increase our exposures because these 2 wards are incredibly high utilizers of nephrotoxins, and that immediately reflected in our increased exposure rate, which jumped to nearly 22. What we found is that despite this initial increase, implementation of Ninja eventually dropped our exposure rate down to 13.3. Nearly identical findings with respect to nephrotoxic AKI events. We had an initial rate of 2.7 AKI events per 1,000 patient days. We saw an increase in our AKI rate when we spread to HEMONC and stem cell. Ninja was eventually able to reduce not only exposure to nephrotoxins, to reduce AKI events themselves. Over the last year, we found that we reduced nephrotoxin exposures by 39% and AKI events by 44%. This equates to preventing 158 exposures and 50 cases of AKI per year. Given short and long-term sequelae associated with AKI, we're really happy with these results. And even in the refinement phase, we continue to adjust our nephrotoxins list and the underlying report logic. We're considering spreading the intervention to ICU populations. We to extend to other teams, provided that we contain additional pharmacy support. And we're also attempting to develop some intelligent exposure alerts in order to automate parts of the process.
So we're happy to share this work with you, and I hope the details are included in the slides so you could replicate some of this work at your local institution. We are always happy to point you to different resources that we use locally so that this can benefit patients at other organizations.
Well, thank you, Dr. Sutherland and Dr. Palmer for that great presentation. And for joining us for the Davies webinar. More use case webinars and information on how to apply for the Davies Award can be found posted at the HIMSS Davies Award website at HIMSS.org/Davies. And so much